A very good morning to one and all. On behalf of the Director and the staff of the Central Health Education Bureau, I extend a warm welcome to all participants as we gather today for the Modular Training Program on Metabolic Disorders for Ayush Master Trainers. This training program being organized by the Ministry of Ayush and the Central Health Education Bureau aims at the capacity building of master trainers from Ayurveda, Homeopathy, Unani and Siddha streams, representing various states and union territories. Before we get into the details of this program, let me take a moment to introduce our organization. The Central Health Education Bureau was set up in the year 1956 on the recommendations of the Bohr Committee, the Central Council of Health, and the Planning Commission of India. Since its inception, CHEB has been playing a crucial role in health promotion and health promotion activities by disseminating vital information to the public and fostering healthy behaviors to improve the overall health and well-being of the population. Along with health promotion, our institution mandate also includes awareness generation, capacity building, and conducting behavioral research. This training program began on 27th October, and we have already trained around 125 Ayurveda, Homeopathy, and Unani master trainers from various parts of the country. As you are aware, today's training session are specifically for the Siddha master trainers. Now I kindly request Raghu sir to address the participants. And just to have a brief introduction, sir. Dr. Raghu is an accomplished Ayurvedic physician and an administrator with over 20 years of experience in Ayurveda, public health policy, and traditional medicine systems. He holds an MD in Ayurveda from Government Ayurveda College, Thiruvananthapuram, a BAMS from Vaidyaratnam Ayurveda College, Ollur, and a diploma in Yoga and Naturopathy recognized by CCRYN. Currently, he serves as an advisor in the Ministry of Ayush with additional charge as a Deputy Director General, Ayush at Ayush Vertical, Director General of Health Services, Ministry of Health. His previous roles include Joint Advisor, Deputy Advisor, and Assistant Advisor in the Ministry of Ayush, as well as Research Officer in the Department of Ayush and Postgraduate Teacher at Gujarat Ayurveda University, Jamnanagar, with experience in teaching international students. Dr. Aragal has represented India at numerous international platforms, including WHO meetings, Indo-US Health Dialogues, and Global Ayurveda conferences. He is a recipient of multiple awards, including 2 gold medals for the Best Paper Presentation and the prestigious Vagbhata Puraskaram. Additionally, he has contributed to key publications under Ayushman Bharat and NRHM. Over to you, sir.
So, this is actually, in fact, it's a continuation of that training program in yet another series of standard treatment guidelines. So, you may be knowing that Ministry of Ayush published this document, and it was released in Pune, in Kaivalya Dham, in the National Ayush Mission Conclave, wherein the Honorable Minister has released this document. And what is expected, what is my briefing will be, because you know by this time that what are the specific objectives of this training program at the national level, and further how to disseminate this into the field level medical officers, whether it is those who are actually working in the various Ayushman Arogya Mandir, or even public health facilities, co-located facilities, primary health centers, community health centers, district hospitals, or standalone, your Siddha hospitals, wherever the doctors are posted, they should able to understand what are the resources available to manage such cases, and based on that available resources, whether they are able to completely treat the cases, or whether there is a need in particularly in certain stage of the disease condition, they may be able to refer the cases appropriately to the higher centers. So all these are part of this our standard treatment guidelines. So based on that, we have already made these STGs. So the journey of this STG will be discussed briefly in this session. as well as what is your specific role in imparting this standard treatment guidelines to the other people who are actually in the field. So based on that, we have made these sessions. So far, our secretariat was Central Council of Research in Siddha, and to some extent National Institute of Siddha also supported us actually in formulating this standard treatment guidelines with the addition of various experts. So one of the important aspect that we would like to highlight is that whether it is any traditional medical system or Ayurveda, ya Siddha, ya Unani, so the basic tenet of these medical systems are the preventive and promotive approach, which actually it showcases in the community. Somehow over the last few, for example, 2 decades, actually large number of initiatives has been undertaken by the central government, and more or less which is actually reciprocated by states like Tamil Nadu or Puducherry, or even states like Kerala and southern states they have reciprocated many of such initiatives. But we felt that there is a need of more and more focus on the campaigns, particularly the behavior change communication, BCC, that is still not percolated into the community. This is highly relevant in the context of the metabolic disorders. Why? Because you may be knowing that considerable population, that too the younger age group populations, are actually due to various lifestyle factors afflicted with such kind of metabolic disorders, whether it is dyslipidemia, whether it is obesity, whether it is diabetes mellitus, or even to that extent even the gout. Such diseases are actually increasingly prevalent in our community. So how to address it actually? The basic, all the medical system, whether it is Ayurveda, whether it is Siddha, whether it is Unani, have a profound background in terms of preventing and promotive. Healthcare is the basic aspect of this these traditional medical system. So that holistic approach that we have to focus and we have to actively advocate in the community, for which different public health programs are already available. But the thing what we are supposed to do is we have to streamline, and periodically we have to engage with the community. So that structure, if you are able to make in the community, then definitely it can be a successful model. And many of you are already practicing and you are making some convergence activities with modern healthcare, and you know that Honorable PM has now advocated the convergence of all the concerned stakeholders in tackling the obesity, because obesity has been a menace, and based on that national level campaign on obesity has also been rolled out. So considering all this background, we felt that there is a need of structured standard treatment guidelines based on the current understanding of the disease profile, where Siddha system can effectively contribute, and also the current evidences generated, particularly in many obesity and dyslipidemia, many scientific publications has been already came into the public domain. So why can't we integrate all these publications, the results of these publications, into the standard treatment guidelines and also to the community, so that at least they will be aware about for their day-to-day lifestyle and other thing, what are the modifications required. Based on that, this STGs has been attempted. And rehabilitation and palliative care is also very important. When we speak about such a disease conditions, you know that chronically, if it is not appropriately managed or if it is felt untreated, it may definitely lead to very severe cases, and which may warrant even the palliative management, palliative care. So there also medical system like Siddha have important role. So based on that, we have tried to describe, by this time you got this STGs physical copies also. So you may see that different manner in which the chronicity can be addressed, how effectively at various levels, at the primary level, secondary level, tertiary level, how the chronicity can be addressed. So that has been clearly mentioned. And another thing is the cost effectiveness. So you know that Ministry of Ayush has published the essential drug list actually. So this EDL more or less consists of the whatever the regional. As far as Siddha is concerned, it is very compact and cohesive. So there won't be much variations in the practices in the different parts of the country. That is what I think. However, there may be certain preferences to the practitioners who use a certain specific medications for certain conditions, which is not there in other areas, other regions of the country. So that aspect also we have to consider when we are including certain medications for these purposes actually. So based on that, the Secretariat in consultation with the national experts, which is including the private practitioners, eminent practitioners, a national level steering committee has been formulated to devise these standard treatment guidelines. Then as far as the infrastructure is concerned, you know that in your state itself, whether it is Puducherry or Tamil Nadu, large number of facilities are actually spanned at the primary level, including the Ayushman Arogya Mandir. Then secondary level, which caters to the community health centers and district hospital, where the Siddha system has been co-located, and also the standalone Siddha hospitals are also some of the area you have. Then in addition to that, 50-bedded integrated Ayush hospital has also been already been made with the support of the government of India. And in addition to that, teaching hospitals. So the entire gamut of these healthcare institutions can be divided into, segregated into primary, secondary and tertiary. And in order to clear guidelines in this regard, Ministry of Ayush also published Indian Public Health Standards. Have you gone through that, anybody? It is there available in the public domain actually in our website, and the IPHS categorically makes certain what you call specification in terms of infrastructure, equipments, furniture, then even the essential medicines, clinical governance, and even the quality assurance system, and the branding. So all these are very specific guidelines has been given as far as the IPHS is concerned, including the HR. What are the qualifications of the HR? What are the ideal capacity building and training needs of this HR? Everything has been detailed out so that state governments were requested to adopt this IPHS guideline. May not be in a 1 day or 2 day. It may take, because a lot of resources are required, because if you want to establish a Siddha system of medicines in your state as per the population norms, maybe more and more number of facilities may be required, more manpower has to be recruited, and more flow of essential medicines for the sustained quality assurance system has to be developed, and you are also part of NABH accreditation of your facilities. So these accreditation, the efforts for the entry level accreditation, everything is a part of the IPHS compliance norms actually. So ultimately, it is expected that for the next 1 decade or so, all your facilities has to be achieved the IPHS norms. So once you want to achieve the IPHS norms, quality is an important aspect. So how to achieve that quality? Quality is not incidental. It should be gained through active participation of all the stakeholders, not only the medical officers, whatever the therapist, the pharmacist, or even the administrators, public health management cadres, everybody has to be actively involved in achieving the quality assurance system. So STG is one of the important tool to achieve, one of the important tool, many other tools are there, but one of the important tool to achieve the quality assurance system, wherein every patient will get, as per his choice, the desired treatment based on the scientific footing that is available in your traditional medical system, and also there is a informed referral system which is actually advised, along with you are well aware about at what stage we are supposed to treat the case, at what stage we are supposed to refer the cases, and also you are supposed to know what are the resources available. For example, in the case of diagnostics, these are the diagnostics which is supposed to be available at the Ayushman Arogya Mandir. these are the diagnostics which is available at the level of teaching hospitals. So based on these actually, whether it is Ayushman Arogya Mandir, teaching hospital, a specific set of diagnostics, specific set of number of essential drugs which are supposed to be made available, and within that whether you are able to manage the cases or not. That is the main purpose of this STG. So based on that, STG has been devised. So currently, whether STGs were not there? Yes. Some of the STGs already Dr. Eugene Wilson and other from the CCRS will highlight it actually. STGs were previously also prepared by the research councils and the national institutes of Siddha. However, actually this is the way in which we approach this STG is based on some kind of convergence with the modern biomedicine. Because why that convergence is required actually? Because now there is a lot of integration. The approach to integration in various institutions are happening. The co-location and other things are already continuing from the past actually, but there is we felt that there is no enough communication between the various systems of practitioners actually. So until and unless you make some standardized document in which you can effectively communicate and you can effectively document your the strength of your system, and that can be appraised to the other any person, whether it is a policy maker, whether it is a modern practitioner, whether it is your own people actually. So that is a need of the convergence, and that is a need of documentations, and that documentations are having certain qualifications. For example, we have tried to make it in a manner that ICD-11 classification. So you are well aware that with the support of the WHO ICD-11 classification, there is a separate chapter 2 for the traditional medical system, Ayurveda, Siddha and Unani. So with that beginning actually, as far as Siddha system of medicines, we have tried to coin each of the terminology that is used in this document into ICD-11 classification. So what is the purpose of that? Ultimately, whenever you prescribe any disease conditions actually, the provisional diagnosis, starting from the provisional diagnosis or even for the longer definitive diagnosis, and even for the referral criteria when you are adopting it actually, you link it with ICD-11 classification, so that your counterpart, whether it is modern biomedicines or even the Ayurveda or any other system of medicine, they can easily understand what you are going to refer, what is the nature of the disease you are going to refer. So based on that, there is a clear understanding between the professionals as far as ICD-11 is concerned, and there is a continuum of care is actually ensured. So based on that, ICD-11 classification are also part of that. Similarly, the differential diagnosis, then red flag signs. Red flag signs is a new concept that we have introduced here actually. It is not a new concept, but at least for our purpose actually, our STG, it has been introduced here with the suggestion from the DGHS actually. So he suggested that there are certain conditions which we should be very careful, so they're cautious when treating it actually. So that caution is very important as far as treating any kind of chronic, so acute exacerbation of the chronic diseases. That is very important, such manifestations may be there. So at that case actually specifically you should have that red flag signs, so the physicians will be highly cautious about the managing such cases. However, if they have sufficient resources and sufficient strength in their traditional medical system, they can treat altogether. But otherwise, within their limited resources, if they want to refer such cases, they can also refer. So based on that, the red flag signs are also mentioned. Then interdisciplinary management approaches are also part of that. For example, integration with the yoga, integration with the dietary aspect. Previously what happened actually, every system are actually set apart and in a standalone manner they were managing. So the combined effect, the combined the beneficial outcome are not available to the patients. So based on that, we thought that yoga, it is a system which can be easily integrated to every system of medicine, whether it is Ayurveda, Siddha, Unani and homeopathy. So based on that, in all these metabolic disorders, appropriate asanas and pranayamas which are actually can be converged with these guidelines, can be integrated with the expertise from the yoga experts actually. So based on that, we have formulated it. Similarly, much of the attention has given to preventive management. So preventive management is very important because you know that in whether it is Siddha, Ayurveda or Unani, these dietary aspects and preventive strategies, even the digestive power, metabolism. So the focus, that focus we have tried to give in each of these STGs. So based on that, that has been integrated. Then the last one is actually scientific evidence. So wherever it is available, wherever it has been documented, even though it is various levels of evidence. So you know that apart from the classical documentation, there are various levels of evidence. Most of the teaching hospital, you are actually, some of you are working there. There you teach the students specifically different kinds of evidence generation, whether it is observational study, whether it is controlled trials, including the RCTs, or even up to some of the studies has been, particularly in the context of the yoga, large number of systematic reviews and meta-analysis has been already been done. So if at all this has been published in the high impact journal. Hello. So on that basis, actually, this scientific evidence generations are also being appropriately integrated into this STG. So whereas the concept is not new to the healthcare systems, they have long been recognized as essential tools for the ensuring evidence-based, standardized, and rational treatment practices. And as far as Ayush is concerned, that is what I again reiterating that we are now already published the musculoskeletal, then this metabolic, and now we are working on the dermatological disorders. So this will be continued within next 1 or 2 years. We intend to have in most of the disease condition where the traditional medical systems have strength and where the appropriate convergence can be made. So all these systems we will make the appropriate STGs along with the appropriate algorithm also. So now specific algorithm in a single picture we have not may not be mentioned, but we will come with that also, and we will also come with certain IEC guidelines to the mass awareness program. So modern research methodologies and outcomes data which need to be incorporated alongside the classical Ayush principles, and also the STGs provide a credible basis for the inclusion of Ayush treatments to public health programs. Ultimately, most of these things will be integrated into the public health program. Currently, we may not have any specific public health program to address only all these metabolic disorders, even though NPCTCS program, which may be availed by some of the state governments. Tamil Nadu, maybe NCD program may be there, but NPCTCS as such may not be there. But actually, some of the state governments has availed NPCTCS program. So there, diabetes mellitus and other NCDs have been actually targeted. So we can think about some specific program for dealing with the metabolic disorders also. So there, these STGs will be very useful. So how we have made it actually? There was a national expert committee which is chaired by DGHS. Members include directors of Ayush Research Council, directors of national institutes, and eminent Ayush practitioners and academicians, and modern medicine experts from the institutes like Lady Harding Medical College and RML Hospital. So their experts were also inducted to the national level expert committee, and they actively contributed, particularly in the context of the diagnosis, differential diagnosis, different referral criteria, red flag signs. So all these aspects they have guided us, and based on their specific consultative inputs actually these STGs have been firmed up. Once this draft has been firmed up and which has been thoroughly reviewed by the Secretariat of the CCRIS and inputs from the NIS, then later what happened, these guidelines will be again reviewed by an editorial board. So that editorial board also gone into detail by reading the line to line, and based on that the final publication came. Then as I mentioned that the main key features of the STGs are it is multidisciplinary, it is evidence based, and also clinically sound and implementable across healthcare settings. Very specific clinical outcome scale also, which is usually in the normal clinical setting, many of these clinical outcome scale may not be very elaborately elicited. But certain conditions we want that clinical outcome scale. So that is why we try to integrate some of the prominent clinical outcome scale which can be practiced at least in the tertiary care level also can be integrated. System covered Ayurveda, Siddha, Unani, Homeopathy and Yoga integrated throughout. Then approval, after the approval, we thought that there should be a national level STG training program, modular training program. And once you are trained, then what you will do? You will dissipate into the entire community actually. Entire community in the sense of the medical officers community. So naturally, many of the practitioners are outside the public health system. Private practitioners, large number of private practitioners may be there. So how to reach them actually? So in order to reach them, actually we have tried to communicate with the national commissions actually, National Commission of Indian System of Medicines and Homeopathy. So they will be widely circulating to all the teaching institutions and even for the practitioners also, because now the hard copy may not be available, but at the soft copy at the different websites this has been posted. Even our DGHS website it is there, Ministry of Ayush website it is there. So you can see these STGs in that, whether it is musculoskeletal and metabolic disorders, it is available. So now there is a specific template in which we have prepared this one. Name of the disease, case definition, introduction, clinical presentation, clinical examination, differential. More or less it is the standard format which is used in the STGs, but however with a certain additional points. For example, this preventive management, the dietary specific practices along with yoga and pranayama, then similarly the red flag signs, then supportive investigations which can be classified into different levels, and even this standard template is applicable to each level, level 1, level 2 and level 3. So based on that standard template has been presented, and along with lastly the references for the research publications and other things. So I mentioned all these things facilitate interdisciplinary learning, treatment options at various levels of healthcare based on the essential drug list, and remember that there are certain medications are also included in addition to the essential drug list. So for that, what you are required when you are in the subsequent training, you have to advise your medical officers to have with the local purchase and other policies. Actually based on that, these medicines has to be obtained actually, and this is as per the recommendations of the technical committee. We are, in addition to the existing essential drug list, some of the medications may also be required to treat such cases, whereas maximum we have tried to collate to the existing drug list, particularly at the tertiary level. Tertiary level, the choice of the medicines may be little bit should be elaborate. So based on that, that also has been included. So as I told, there are three beneficiaries. The primary beneficiaries will be the practitioners, whether it is in public health facilities, whether it is private practitioners. So these people will be the primary beneficiaries. Secondary will be the policy makers actually. Ultimately, these documents, even though they may not understand the nitty-gritty of these documents, at least they may know that there is some kind of scientific documentation as far as these disease conditions are concerned. Particularly, I can tell about the dyslipidemia. In dyslipidemia, generally not a standard treatment guidelines as a generally it is not approached actually, whereas it should be, because nowadays even for the younger generation, very long standing without understanding clinically visible symptoms, dyslipidemia is happening actually. So that will lead to further complications and chronicity in the later stage. So that has to be addressed at the early stage itself. So based on that, these kinds of documentation has to be appropriately oriented towards our policy makers also, so that they will be well aware about the strength of our traditional systems. And lastly, the indirect beneficiaries of obviously the patients themselves actually. In a large cohort, actually if you are able to make an advocacy to these such kind of beneficiaries in a particularly public health program, whether it is in the village health sanitation committees. So that will be the immediate impact it will be coming to the community. In the longer run, you can also assess after 6 months what happened. Suppose they adopt this preventive management criteria that we mentioned in the STG, what happened to this community, whether is there any what you call more and more disease is afflicted them, or even there is a reduction in that particular community. So such kind of small studies also you can conduct, and you can document it, and you can send that report to us also. Then rationale for the modular training already I mentioned. Now after this national level modular training, what we will do, we will give you this not only these documents, even the proper training plan for the next 6 months, how to conduct further in the field level these training programs, and also we will try to make a what you call IEC of this specifically the English and Hindi version. We will, so you can translate into the Tamil in your regional language also, so that the community, larger community can be involved. Then the reporting format also we will be dissipating to you, wherein how many trainees you have been conducted the training program, and what are their perceptions, and even what are the training outcome. So all these will be captured in the training format. Then vision to promote standardized, safe and efficacy Ayush-based clinical care through competency-driven training. The goals are build the capacity of the Ayush practitioners to apply STGs consistently, ensure evidence-based and patient-centered clinical decision-making, strengthen health system integration through harmonized treatment of protocols and referral system, contribute to improved public health outcomes through standardization. So core objectives of the training system, there should be a system, strengthen the documentation, referral and feedback mechanism. So referral system has to be clearly integrated into the existing system. That is very important aspect actually. Even the IPHS also we have emphasized it actually. So in order to make that referral system, you have to gear up yourself and your hierarchy. In the hierarchy, the institution which lies above your hierarchy, and also referral system will be successful only if your allopathy counterparts also are ready to receive your patients actually. So for that, enabling mechanism has to be made at the state level. So this is a beginning. Actually, we expect that by the rolling out of these STGs, naturally their convergence and communications, then the referral system can be evolved. Attitude, obviously the ethical practice is the cornerstone of any STG actually. So patient-centered care also will be part of that, and understand the principles and structure of the Ayush STGs, skills apply STGs in diagnosis, prescription and follow-up. So state level rollouts and dissemination, this as I mentioned earlier, actually within next 6 months you are supposed to conduct this training program. So appropriately you brief your directors and commissionerates in the state level actually, so that you can send them a, as per our guidelines, the training plan for the next 6 months at various districts actually. So suppose there are 39 40 districts in the state, then definitely you have to make it in initially the region wise actually. 6-7 districts at a region, another 6-7 districts in another region. So based on that, the training program has to be conducted, and wherever the training programs you can conduct, even the teaching hospital you can select actually. That would be an ideal platform where the resources are available in terms of your resource persons, in terms of space, and so based on that, and financial resources, generally we support in the National Ayush Mission if it is appropriately proposed in the state annual action plan. So there is no problem as far as STG training is concerned, there is no problem. So you can have that, only provided your commissionerate should be little bit active to achieve these targets actually. Then to ensure the continuous and flexible wide-reaching capacity building, the Ayush vertical is leveraging digital health platform. So probably you can at a later stage can report to us back some digital manner actually, what are the training load you have trained and how many trainings such conducted and what are the outcomes. This reporting system, as and when we share you can report back to us. Resources are disseminated through the National Commission, already I mentioned. national institutes and research councils and the regional research councils institute, Siddha, Madurai or some other region, whichever regional research institutes are there, they will be also collaborating with you to conduct this training program. We will request them to do it actually. Then expected outcomes, uniformity in service delivery across facilities, increased patient safety and satisfaction, enhanced clinical competence and confidence, strengthened integration with the national health programs and evidence-based data generation for policy decisions. So you expand training under the NAM to all states, continuous updating and STGs with emerging, and remember that these STGs will be updated again because based on your feedback, that is why we are saying that after conducting the training program, after implementing this STG, you have to assess it actually, whether the practitioners are actually undertaking these training programs or not actually, this implementation of these STGs. Once these STGs are implemented, then they may come up with certain problems also. Say these medicines are not available or these medicines are not appropriate and there is a follow-up period is also very difficult to monitor. So many such issues may crop up actually. So that can be collated at the national level and again a review can be done during the implementation. So that can be updated. Even new publications may come in the later stage. So based on that publications, new medicines or new approach interventions may also can be added to the STG. So thank you. This much only I have to mention. If you have any suggestions, comments in the briefing session, how to go forward, then I can answer to that. Okay. Any point? Non-government practitioners also can be given, provided, because first we will focus on the whoever in the public health facilities. Thereafter, because you know that and the national commissions now insisting on after renewal of the registration for 5 years, there should be attending the CME, continuous medical education. So as resources made available to you, you can include the private practitioners also. There is no problem actually. So we will request national commissions themselves to conduct such a training programs actually. Any other suggestions or comments?
So what is the role of teaching institutions?
Teaching institutions will be the most ideal place to conduct this training program because otherwise getting the auditorium, getting the resource persons, you will be the master trainer. But for taking the other sessions, you can invite 1 or 2 members from the teaching faculty. Suppose Gunapadam, any other departments, somebody you can invite, so that naturally they may be well aware about these STGs. But provided you just beforehand you have to provide these standard treatment guidelines. So that means at least more or less it should be followed actually, STGs. Any other comments? So thank you all. So you will be going with even including the modern orientation session. One session will be there. Then in the time permits, I will come back in the evening also. Okay. Thank you.
Thank you, sir.